Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and I'm always excited about our episodes because I think they're all super interesting, informative, educational, and hopefully entertaining. But this particular episodes, meaning I'm not even sure, we may even do a two-part of this, I'm actually the most excited about because what we're going to be talking about is operating room or OR nightmares, but not from my perspective, which many would say is biased or limited, but rather from the perspective of a very well-respected nurse, now nurse practitioner, who is one of our newest additions to the Rahban family here at our office, and her experience and her exposure with her friends and her group and her community of nurses and what they've seen happen in the operating room, which is basically what we've been talking about in many of our episodes, which basically is what we read about in the media when things go sideways. But I just found it so fascinating and so interesting hearing it firsthand from her own perspective. So you're definitely going to want to listen very closely to this entire episode, and maybe we do a follow-up episode as we kind of traverse sort of the landscape of operating room environments. Remember, the key here is kind of like a mechanic. When you go into an operating room, you're out. You're asleep. You have no idea what's happening, and you assume, as you should, that your physician and the environment around you is safe and it's actively engaged in keeping you safe. But the truth is, like a mechanic, when you go and you get your car back, unless you're an expert, you have no idea what happened while you dropped your car off. And so I think it's going to be very eye-opening. I hope it's going to be educational, that you really, when I say do your homework, I'm not just talking about the basics. Oh, I went to a board certified plastic surgeon in Beverly Hills. Like, okay, well that should do it, right? No, essentially all the stories we're about to share with you are board certified plastic surgeons in Beverly Hills. So you're going to want to dig deeper. You're going to want to really get to know your clinician. And there's an essence about each doctor and the way they run their environment that will echo through, because at the end of the day, the captain of the ship is the surgeon. And so where all of these issues come from when you're in the OR is the surgeon is the one who is dictating and orchestrating. And in my humble opinion, is ultimately the one to blame, because when a patient agrees to go under anesthesia, they're trusting that surgeon. And then the surgeon decides who the OR nurse is, who the tech is, who the anesthesiologist, what equipment is used, what materials are there, what happens pre-op, what happens post-op. It's really the surgeon's show. And so they like to play dumb and say, oh, I didn't know, oh, this, that, the other. But the reality is that you're the point guard. You're the point guard. And if something goes sideways, you're the one to blame. At any rate, that was a very long introduction. We want to welcome Paula to our show. Paula is our new nurse practitioner to our practice. She helps run our ORs and our clinic and all that good stuff. And welcome to the show.
Thank you.
Paula was like, I don't know if I want to come on the show. And I said, you have to come, because the information that Paula has, or better yet, the experience that Paula has, I could never share with you. I could make examples of it, but it would just be theoretical. Whereas Paula now 6 years have been in the OR environment, right? And has probably circulated through, you want to say 40 different surgeons' operating rooms. Probably around 40. And has exclusively been essentially in Beverly Hills. And Beverly Hills is no different than any other place, except in that in the patient's views, it should have the highest standard. So if these issues are occurring here in Beverly Hills, you can just assume 100% they occur everywhere else. Because, sometimes we watch the media and we hear about these like holy shit experiences. Oh, anesthesiologist puts his penis in a patient's mouth, crazy things. And you're like, oh, well, that's in Mississippi. That wouldn't happen in like somewhere like Beverly Hills. Well, no, it will. So welcome. Thank you for coming.
Yeah.
I think it's as everyone who comes on the show, there's always a little sacrifice they have to make. So if patients come in here and they talk about their journey, they're sort of exposing themselves. Mm-hmm. And as a nurse who's reputable and sort of has your own sort of privacy, if you will. Coming and having this conversation exposes you, but the goal is that you feel by sharing your stories, what we're going to be doing today is educating people so they can protect themselves. So that in case your mom or my sister or someone goes out, they're a little bit more savvy. Of course, you're still asleep and you never can be 100% sure, but certainly having more information is better than having less information. So we're going to dive right in, and we're going to start with the thing that I have mentioned many a time, which is number one issue is you pick Dr. Rahban as your surgeon. And the assumption that's made is that you go to sleep, you have a procedure done, a breast aug, a tummy tuck, a 360 lipo, a facelift, whatever. And Dr. Rahban, naturally, is your surgeon doing the surgery. Who the hell else would be doing your surgery? But as I have mentioned many a time, there are people that come into the OR to help the quote unquote, for those of you listening, I'm doing quotes, to help the surgeon, but in my opinion are actually doing surgery and are not helping. A tech helps a surgeon, hands them instruments. A nurse helps a surgeon by retracting or exposing, but no one should be operating on the patient. So I've made it a comment many times. I tell every patient, a simple example, very simple, is that when it comes to closing, I close everything. And they're always like, okay, yeah, sure. Whereas I am 99% of other surgeons have someone, the tech, another surgeon, a junior, a whoever, closing some, if not all of it. So tell me your experience about this other person helping. So let's start with simple and work our way up to, are you fucking kidding me?
I mean, many times patients go to sleep and they think, like you said, Dr. Bond's doing the closing, but there's been many times when I see patients go to sleep and like Dr. Bond will be closing half of the patient, and then, a different surgeon and he could be, like a fellow or a junior, like you said, closing the other half. So, you are going to a specific surgeon, a different surgeon's doing half of your case. So that's been that, but it's also been kind of like, okay, they're another surgeon. All right.
Yeah, so that example, that's a great start, is sort of the least egregious, right? Because technically they're surgeons, albeit I personally think the surgeon, the main surgeon, has an obligation to share with the patient, hey, by the way, I have my fellow, which is a surgeon in training, or a junior doctor in the room helping me. That's not illegal, that's actually legal. But the illegal part, in my opinion, is the non-transparency of it. But even there, you could say, well, it's part of my team. So that's number one.
Yeah, there's been many times, I think you're one of like the only two doctors I've ever worked with in Beverly Hills that close the whole time only you're doing it. Everyone else has a tech doing it. A tech has, probably, the surgeon will do like all the deep layers and then the tech will close the rest. The surgeon will usually scrub out. They won't even be in the room for it. And then the tech's doing it mostly. And that goes anywhere from the face to the body, anything like that. And it's not right because, again, the patient thinks that the surgeon's doing everything. And here's this tech that they've never met before who I think tech school is like 6 months or something like that, closing majority of the surgery.
So let's unpack that. Number one, in my humble opinion, one of the most, if not the most important layers of closure is the goddamn last layer, which is the layer you see, right? So deep layers are important because they hold everything together. The last layer is the layer that leads to most of the ultimate scar. So plastic surgery is about the scar. Like, I don't want to get a tummy tuck because of the scar. I don't want to get a breast lift because of the scar. I don't want to get a facelift because of the scar. So in the most critical part of the surgery, you have a tech. And as you said it, a tech is, first of all, it's illegal. A junior surgeon, not illegal. A tech, illegal. They have no right touching a patient or operating on them. They're operating when they're closing. And as you said, a tech can go to school for like 6 months. The purpose of a tech is to hand you instruments. Hey, it's like the caddy to a golfer. They're there to hand you the 9-iron. They're not there to swing the golf club or putt for you. And so you're absolutely right. So the tech is closing. And moreover, at least sometimes when I tell patients, I'm like, the doctor will close half and then the tech will close the other half. But let's be honest, the doctor's usually what?
They scrub out usually.
He's scrubbed out. It's like,
Go eat their lunch. Do
they're
whatever
going to go
they
eat
have to
lunch, answer some emails, whatever. They're not even in the goddamn room.
Yeah.
And you would say 90% of times that you've been in the OR. Now you've been in 40 ORs, probably watched, let's say in that 40 ORs, you've seen 40, 50 surgeons, or better yet, 30 surgeons in Beverly Hills, all very prominent. Paula's a very desirable nurse, so she's only in the best of the best ORs. What percentage of the times have you actually seen the tech or someone closing?
Probably like 98% of the time, I can think of one other surgeon other than you who closes the whole thing.
Right.
So.
And it's just, to me, it's just batty. I know that I do it and it's like normal for me. And yes, don't get me wrong, I don't enjoy doing it. I mean, so let's back up here. Why would that happen? Because closing is a pain in the ass, right? Patients don't understand that. Closing is the time-consuming part. Making your dissection, removing the flap, doing all that is a third of the time. The other 2/3 of every surgery in plastic surgery is closing. Layer 1, layer 2, layer 3, blah, blah, blah. So when you do tummy tucks and breast reductions, God, it's hours of closure. I just had my trigger finger injected. I don't enjoy closing, but that's what I got paid to do. That's the job. So the reason why they don't want to do it is just simply because they're lazy. They just don't want to do it. So that's that. Then we get to the next level, which is like your brain is going to explode. So listen very carefully. Thus far, all we've talked about is closing. So technically, it's the easy part of the surgery. It's very important, but it's not like, you need to, it's very basic. You just got to follow the instructions. What else have you seen?
This one I was like shocked at, but there has been points in multiple surgeons' ORs, and it wasn't just one surgeon, where the tech is bovying. Maybe you can elaborate on bovying a little bit. So the tech is bovying, they're cutting off flaps, they're using a blade, and they're usually on half of the body, like when we're doing big body lifts, and then the surgeon's on the other half. So they're both working at the same time. And that was when I was just like, my mind exploded. Yeah. I just could not get behind that. And then they do these like huge 360 body lifts, arm lifts, all this stuff in like 3 hours. And the patient's like, oh, that was so fast and amazing, which is just so misleading. And it's so horrible because the surgeon's not even the one doing half of your surgery.
Right. And so what you're saying essentially is the tech is operating. Yeah. Because at that point, there's no arguing. Yeah. The surgeon will argue, well, he's not really operating. Mm-hmm. He's closing. Mm-hmm. Well, closing is fucking operating. Mm-hmm. But you can't deny the fact that you're both simultaneously. Boving is using the cautery, which is cutting with electricity so it doesn't bleed. It cauterizes the blood vessels. So, when we cut things in surgery, we use an electrical device that sort of cuts and coagulates at the same time. That's operating. Using a blade to cut off things is operating. If that's not operating, then what am I doing? And the idea is, again, why would someone do that? It accelerates the process. We're in and out quicker. This is exactly what I tell people when they come for what? Body contouring. So, hi, Dr. Rahban. Hi, nice to meet you. I've lost 100 pounds. Oh, wow, congratulations. I have a shit ton of loose skin. Where is it? My neck, my arms, my thighs, my abdomen, my breasts. Okay. What do you suggest? What I suggest is 3 surgeries, 3 separate surgeries. Yes. Surgery 1, we do X. Surgery 2, we do Y. Surgery 3, we do Z. Oh, wow, I have to do 3 surgeries? Why can't you do it all at once? Because I'm the only one there. Like, I can't do 5 surgeries in one time. Oh, well, I went to this other 3 doctors, and they said they can do my arms, my legs, and my abdomen at the same time. And I always tell them the only way that's going to happen is if multiple people are working you simultaneously. There's no other way. And they're like, what do you mean? What other people? I'm like, yeah, the tech, the junior, the fellow, the whoever. It's like, I call it Formula One. Have you seen the pit stop at Formula One? Do you know why they can do it under 3 seconds?
Oh, yeah.
There's like 8 people there, like 2 per tire.
Yeah.
So there's like 10 people in a single pit stop. Mm-hmm. Well, shit, yeah. And I think that's crazy that, and it's not, you said it's not one surgeon. It's not like, oh, that one guy. oh, that crazy guy over there. I get what I want everyone to listen to. Everything we're telling you today is not one isolated thing you see on Extra. Oh, that one dancing doctor on TikTok. This is fucking everybody, okay?
Yeah.
And so, here you are like, whoa, 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 what is this? So that to me is just mind-boggling, right? The next level, which you shared with me, and I actually, for you to share things with me and for me to be like, what? That takes it another whole level, which just goes to tell you that's why I was so grateful that you're like, okay, yeah, sure, I'll come and shed some light on my experiences, is this notion that one surgeon is in two separate rooms.
Yeah.
So let me explain everything to you guys. When I operate on a patient, I am in a room with a patient from the minute they go under anesthesia to the minute they come out of the room. That's the patient. I'm operating on them. What you're telling me is that you experience a scenario, or I don't know if it's scenarios, in which a surgeon was in two rooms with separate patients going back and forth.
Yeah, so it was one surgeon in particular, and he'd had two operating rooms in his office, and he would bring both patients in at once. There was two different anesthesiologists that would put both of the patients to sleep, and he would have like his fellow in one room. Like it was mostly all fast cases, so like breast augmentations. So he would have his fellow, create the pocket, do everything in both rooms, and then he would just pop in. He wasn't even stir or anything. He would just take a look. Okay, that looks good. Call me when the sizer is in, which is the thing that you put in before the final implant. Then he'd pop into the next room. Okay, that looks good. So he has two patients going on at once, and then he would get sterile and just put the final implant in. And he would just go from room to room to room. So within like a whole day, from like a 6 a.m. to 3 p.m. day, he could do like 40 breast dogs, which is just like crazy because he has both rooms going.
Did you guys hear that? Is that insane? Is anyone freaking out like I'm freaking out? Like that's just, you're highly efficient. It's, wow, what a great system you have in place. That's illegal. You're taking care of a person. Yes, it's inconvenient. The whole purpose of surgery is inconvenience. I could come up with 100 ways to do my surgeries faster. I am a really, really efficient dude. My wife makes fun of me. Like, I'm figuring out when I have to do errands on a Sunday, I'm mapping out the route so that, God forbid, I have to double back between a place. That's how efficient I am. But when it comes to the OR, I'm not looking for efficiency. I'm looking for the most inefficient, safest, highest level way to do it. And that's my ass sitting in there from beginning to end. Of course, I have two Rs. We have two ORs. We could literally bring two patients in as even what you described is nuts. But if I wanted to, as one of my patients is almost done, right?
Closing.
Josh is going to start closing. Josh is my tech who's salivating to close because Josh is accustomed to closing at his other locations in his other OR experiences, exactly like Paula, he was closing. So I leave Josh alone. He closes my tummy tuck. Now I have my second OR. Patient is being intubated, which is even less egregious than the scenario where two patients are asleep simultaneously. And as this one wakes up, that one I get started. That's highly efficient. Still wrong because the patient's being closed by Josh, but that's at least a little even better than two of them at the same time under two anesthetics being operated on by essentially a fellow. So that was like, oh my God, I can't believe it. So then we move to another level. So again, you assume you're in Beverly Hills and there are no corners being cut, right? When you go to an operating room, you have no idea how much stuff is going on, how much equipment is in place, what all the safety measures are. Yes, when everything goes great, it's like symphony. Oh my God, you went in, boom. In your office, you had major surgery. I mean, what are we talking about? We used to do that in the hospital. So when you do it and it goes well, it's beautiful. But if and when it doesn't go well, it's a shit show. A true shit show. Because you're not in a hospital, you don't have 100 staff members, you don't have an ICU, you don't have all of that stuff there. And that's the time where outpatient surgery centers become very vulnerable. When it comes to efficiency, they crush the hospital. When it comes to cleanliness, they crush the hospital. But when it comes to catastrophes, they get crushed. And so we'll talk about safety equipment. So let's chat about some of the things you see not there. By the way, all of this is required. This isn't an option or like, hey, Dr. Rahban, you're just a really tightly laced guy, so you have all. No. If you have a surgery center and it's accredited, these are required to have accreditation. So what are some of the stuff you've seen not there?
I mean, there's a certain thing a nurse does when she comes in the morning. So there's been a lot of centers that I come in and I go do all my checks of everything, and I'm, when it's a new center, you can't seem to find things or something. So I'd ask, oh, where's your crash cart? I just want to make sure everything works. So you have all the medications. God forbid we have to use it. And there's been so many centers that just don't have a crash cart or a working crash cart. And I'm just like, so what are you guys, how are you operating? Like, that's something you need to operate. God forbid you ever have to use it, but you need it there. That's a huge one.
So let's stop with that for a second. And by the way, the question is like, oh, you know how many times Paula's walked out of a job where she's been asked, now she's with us and she's in a stable home. But what Paula did as a nurse is what 99% of nurses do. 99% of OR nurses rotate. They rotate. They rotate through different centers. On Tuesdays, Dr. So-and-so needs me. On Wednesdays, Dr. So-and-so needs me. And they may rotate through 2 or 3 or 5 facilities at a time. But very few nurses are Dr. Rahban's nurse. The reason is you just have to have enough cases to sustain that nurse 5 days a week. Otherwise, the nurse needs a job 5 days a week. She can't be in the OR 1 or 2 days, and then what am I going to do the rest of the time? So you show up to facilities that you are asked to come to and so on, and sometimes it's like, whoa, what the hell? What kind of place is this? And it's only then that you realize it's like that, and then, Paula will walk out. Like, I can't stay here. Because remember, she gets exposed, right? Even though it's a center and they have accreditations and there's a medical director, etc. So can you just imagine what a place that puts a nurse who's coming in to just do her job, puts them into this position where they got to come to a facility and just be like, you guys are this is wrong, right?
Yeah.
How many times have you been like, I can't be a part of this thing?
A lot. I've walked out a lot, and I feel bad because then they don't have a nurse, and the surgery will ultimately, hopefully, has been canceled. They don't operate without a nurse, but it's my license at the end of the day, and it's also just not right to put patients through that.
Right, and so in her world, Paula is doing what I do in my world, which is we draw the line. We have integrity. Our job is to do the job correctly. So if a patient in my end comes and hasn't done their medical clearance, what do you know? They cancel the case. What do you mean you're going to cancel the case? There's thousands of dollars on the line. Can't help you. She's just not ready to do surgery. So Paula has been put in that position multiple times. So back to what I'm talking about. What do you mean you don't have a crash cart? Like, you may have nothing in your facility. Nothing. But you have oxygen and you have a goddamn crash cart. Like, that's the minimum you have to have. And what a crash cart is basically a cart that has everything in it that you would need in the case of a catastrophic complication like cardiac arrest, pulmonary arrest, anything, a stroke, anything that would be like life-ending. You don't go scrambling around the operating room. Imagine a new nurse, oh my God, where's your Jantraline? Blah, blah, blah. You just go to the cart, which is labeled and marked, and every drug is there, and you just open the cart and you administer the life-saving treatments that need to be administered. Like, that's the bare minimum. And to imagine that you're flying an airplane with, zero radar is insane to me. What else have you seen that's not in the operating room?
Basic things. Like, I went in one time when we were about to start the case, and I went into the operating room to make sure all the things I needed for the patient were in there, and they didn't have an SCD machine, which is essentially just kind of compression that we put on your legs to help prevent blood clots. And this patient was getting like lipo 360 body lift, breath, like a long case. And I asked the surgeon, I'm like, hey, where is like your SCD machine? And he's like, oh, we don't use that here. And I was like, so I'm like, what do you mean you don't use that here? So what do you do for blood clot prevention? Like, anything? He's like, oh, no, we're fine. And he's just trying to brush it off. And then the tech there told me, she's like, oh yeah, like it broke a couple months ago. He hasn't wanted to get a new one. And I was like, what do you mean I don't want to get a new one? Like, you have to have that on every patient in surgery. So I was like, I'm not doing the case without a machine. Like, that's just, this patient's going to get a blood clot. Like, what do you mean? So it's just things like that where they just try to cut corners and like turn a blind eye to things. But when things go wrong, like they go really wrong.
Really wrong. So what is it? So again, we're not talking about in my operating room. I like to spend money on things that, oh, wow, you have Ethicon sutures? Wow, those are expensive sutures. No, in my facility, we use the cheapo sutures. We still have the sutures, right? We don't have Godiva chocolate. We have Hershey's, okay? But these things are not optional. And when you are put to sleep, one of the many risks exposed to you is a blood clot in your lower extremities, in your legs, in which you then shoot that blood clot to your lungs and you get a pulmonary embolus and you drop dead. And why that happens in the operating room is because you are laying there just stagnant, just laying there lifelessly, and the blood in your legs accumulate, they collect, because we've given you medications that dilate your venous system, and they sit there like a lake and there's no movement in them, and then they clot. Then you get up, you go home, and you move around, like when we talk about people sitting on an airplane for 12 hours and then they get out in the airport, and then as you move around, that clot that's in your leg dislodges, shoots up into your lungs, and boom, you just drop dead, right? Pulmonary embolus. So in order to reduce, not eliminate, reduce that risk, we put on these compression devices.
Yeah.
Thank you. I had a like Alzheimer's meets stroke.
Okay.
And the idea is that they mimic your walking. So while you're laying there lifelessly, they're acting as if your calves are working and they're circulating the blood so that there's no stagnation. Not only do you need them, you need to put them on before the patient goes to sleep. I'm a stickler. I come in the room back in the day when I would be in other facilities, and I'd come in and the patient's asleep, and then I'd come up to the nurse, I'm like, hey, why the hell are these leg squeezers not on? They're like, oh, okay, yeah, I was gonna put it on in a second. I'm like, wait, you're gonna put it on in a second? Do you put the bun before you put the patty? What does that mean? There's an order to this. They need to be on, not only, they need to be on before they go to sleep, because once the anesthesiologist gives them the drug, starts the dilation. You put it on after, for all you know, you're shooting the clot out. So that's how important this is. And again, it's not an option. You don't have an option to have these things. These are required. And to think that you've been in facilities, again, I'll keep underscoring this throughout this episode, reputable surgeon, Beverly Hills, not some shoddy ass place in some strip mall in Miami. Okay, then we're gonna go to the idea of you'd come into the OR and you'd see that they're reusing stuff. So this is an interesting concept, because there's this fine line that we say in everything we do today. It's about carbon footprint, right? So interesting, we're talking about carbon footprint here. It's the idea of wastefulness. One of the things I experience and I've watched for 20 years is a total amount of waste we have in our medical system. If you've ever been in a hospital, they literally open something on the back table. They don't use it. They just open, like a doctor has a preference card. So, oh, we're doing a total hip today. Great. So the nurse, before the case starts, opens up 15 things, sets them on the back table so we're ready. The surgeon comes in and they're like, nah, I don't want to do that today, or I'm going to do this or whatever. And all that stuff gets thrown in the trash. So in my opinion, that's waste, because I've done many mission trips in Guatemala and El Salvador, and we have operated on children and saved their lives with so-called stuff that's expired or used, right? Because at the end of the day, we don't have anything else. So there is this fine line between reusing things or re-sterilizing things. So if you open up a package of laps, which are just the towels, for example, and you don't use them and they've never been touched, and you are able to re-sterilize them, I think it's arguable. I think that's, in my opinion, saving the world. But you're not going to use a suture that's gone through a person's body, been contaminated, used half of it, and then re-sterilize that. So I think you've seen some things being reused or repurposed that, frankly, is not in the purpose of saving the planet or the landfills. It's just old-fashioned cheap. You're trying to cut corners. And tell me what some of the things you've seen.
Sutures is a big one. I'm accustomed to, there's a suture left, you don't finish it, you put it in the sharps container, you dispose of it. So there's been a lot of centers I've been at where the techs, who are usually there full time, will be like, oh, where did you put this suture? And I'm like, oh, I just put it in the sharps. I'm like, oh, no, like we keep that. And I'm like, what do you mean you keep a suture? Like that was just inside of someone else's body. You're going to use that on a different patient. And they'd be like, yeah, the surgeon wants to do that because the sutures are like $30 each. And I'm like, what do you mean you want to reuse the suture? So things like that I've seen a lot of. Reusing different like sterilizers, like for breast implants and things like that are one-time use. Also, I've seen a lot of that being reused because they tend to, be expensive and whatnot, and surgeons want to reuse them. So a lot of surgeons do that. I've seen that a lot too.
So, for example, one of the things I remember early on in my career, I think I was out a year or two. I went to, kind of like what you're doing, I went to a lot of centers, right?
Mm-hmm.
I was a hired gun. Wherever there was a case, I would go because I needed to be busy and I needed to work and I didn't give a shit how much money I made.
Mm-hmm.
I remember showing up in this one guy's facility, just like you, didn't know where I was going, really, to be honest with you. And to be honest with you, I wasn't in a place that I am now. I couldn't call the shots. So I show up, it was an OBGYN who was doing cosmetic surgery. Again, back in the day, I didn't really fully understand cosmetic surgeon, plastic surgeon, board certified, non-board certified. He wasn't doing the case. I was doing the case, but it was his center. And I remember starting the case. First thing we noticed is that they didn't have backup oxygen. No backup oxygen. What does that effing mean? How do you jump out of an airplane without a backup parachute? Like, so the anesthesiologist was freaking out about that. And then the next thing was, they were like, we started the case, they used a backup small canister, and then the Bovie wouldn't work. And I'm just like, guys, I have a bleeder here, I need a Bovie. And they kept reusing the Bovie pad. And a Bovie pad is about contact. The gel has to stick on your thigh so they can conduct. And it wasn't working because they reused this Bovie it's $3. You're charging me, who's charging the patient, thousands of dollars. You know what? You want to save? Save. Tell the patient, hey, we're going to reuse our suture, and instead of charging you $3,000 for the OR, we're going to give you a discounted rate. It's $500. Are you okay reusing suture? Hell yeah, if you give me $2,500 off. That's between you and the patient. You cannot charge them Ritz-Carlton prices and then make it a Motel 6. Like, what the? So we had that. Then I was like, I need a suture. I need this suture. We don't have that suture. I need this other suture. We don't have that one either. Why don't you use this instead? What do you mean use this instead? I need oil. We don't have oil. Why don't you use coolant? So I ended up scrubbing out, losing my mind. I was screaming bloody murder. They had to come in I was like a year out from training. So I was in no position to, the wife was running the center. She had to come and calm me down. I was like, I'm calling the fucking, and they were like, okay, let us get you. It was just, and they had to go next door and get all this stuff. It was insane. Needless to say, I never went back there and all that other stuff. But at the end of the day, this is common practice. Common practice is, let's cut corners, let's save money, and let's not tell the patient. And that's how we make a dollar. That's how we make sure our profit margins are higher. There's so much valuable information here that no one knows besides people that are in the business. Mm-hmm. No one understands these things because you have no advocate. You go to sleep, you have not a clue what is being done to you, and you make a very, very large assumption that someone is watching out for you. And while I would say, let's pray that most of the time that's happening, right? Even 5% or 10%. Your experience is insane, right? Because it's saying, wow, I've been to a lot of centers, and I would say that 90% of them are doing something Mickey Mouse. That's just wrong. The last thing we're going to talk about is some anesthesia nightmares. So remember, the nurse, with all due respect, on the totem pole is low on the totem pole relative to the anesthesiologist and relative to the surgeon. In other words, it isn't and again, with all due respect, just for analogy purposes, if a child is calling out their parents, we got a problem here. We got a problem if hey, mom, you're driving erratically. Mom, you should have signaled. Like, wait, you're the parent. Like, you're the one who should be setting the example, calling the shots, setting the bar. So one of the things is often the anesthesiologist is doing whatever more times than not, the surgeon is cutting corners and everyone has to toe the line and everyone has to be button-lipped and the anesthesiologist gets paid by the surgeon. Everyone's sort of at the mercy of the surgeon. But every once in a while, you got some crazy-ass anesthesiologists. Mm-hmm. In my practice, since the day I've been in practice, not the day, but essentially there soon thereafter, I've used the same two anesthesiologists for 20 years because I know who they are, I know how they do it, and then I can say with confidence anesthesia is going to be done right. Most surgeons get the anesthesiologist du jour. They have a few cases a month. They don't have enough cases to sustain an ongoing anesthesia relationship. Their office will call and start scrambling for whoever's available. The patient doesn't know that. The patient doesn't know the pilot is flying with a co-pilot that just happened to be walking by and they grabbed him. So tell me, I think you've seen some anesthesia, like anesthesiologists doing some things and you're like, oh, no, what is going on here?
Yeah, there's been a lot of instances, but there's a lot where a big one is a lot of patients are scared of anesthesia.
Sure.
And they're scared of the word general anesthesia.
Right.
And they think that's just so scary and they much rather do kind of what's known as like a twilight, like a moderate sedation. And a lot of times anesthesiologists, the surgeon will tell the anesthesiologist, oh, this patient wants to do a moderate sedation for like a 7-hour facelift, rhino, whatever we're doing on the face. And patients think that sounds amazing and great, but in reality, with that, they don't have what's called like, you know this, but
they don't know that.
Yeah, what's a protected airway. So essentially, they're not intubated, their airway's not protected. They have all this bleeding, and it's just the way that I've seen some anesthesiologists go about it is they kind of just jerry rig it in order for it to work. So they'll connect oxygen lines with CO2 lines, which I'm just watching and I'm like, I've never seen this in my life.
Right.
Just so they don't have to call it, like quote unquote general anesthesia, but it's just at the end of the day extremely unsafe for the patient, especially for long surgeries. And these patients who are getting it are usually older. So I've seen a lot of that happening just because the anesthesiologist wants to keep the surgeon happy.
Right. So what Paula's referring to is this idea or notion. One of sometimes the most frightening part of any surgery is the anesthesia part. Mm-hmm. And I've had patients who have like, oh my God, Dr. Rahban, I trust you with my life. It's amazing. I am not worried about you, but I'm so afraid to have anesthesia. I have 3 kids. Can you make sure I wake up, right? And so as a result, we've done many episodes on general anesthesia. I brought Dr. Houston on and we talked about it. And it's kind of like being afraid of something that historically was dangerous back in the day, but like we haven't updated our cue cards, mm-hmm. right? General anesthesia today is so safe. Again, everything with the assumption it's done correctly is like I would personally rather go to sleep and wake up and be out of the room and make sure that I was fully under control. So, but a lot of patients are afraid and what they want is to do the surgery, but they don't want to go to sleep. And so there is another method of anesthesia, which is that you refer to as twilight or conscious sedation, which is basically the following difference. The difference is that you are not intubated. So let me explain that. In general anesthetic, they take you deep enough where you're fully out of it, you're not moving, you don't feel anything, your body's disassociated, and as a result, you can't breathe. So we put a breathing tube connected to the anesthesia machine, which is a ventilator, and we breathe on your behalf. The reason why that advancement is so critical is that when you're asleep and you're under anesthesia, your ability to close off and protect your airway, your trachea to your bronchial to your lungs is compromised. So if you were to vomit or fluid were in your mouth, normally, you and I are talking here, if you were to vomit, your body would close off the path to your lungs. You're not going to vomit and then it goes into your lungs. You'll immediately die because you'll get all that shit in your lungs. It causes ARDS, inflammation, and your lungs shut down and you can't breathe. So in anesthesia, while you're knocked out, we block and close off your airway. So your airway is protected because it has a tube in it, it has a balloon in it. So if you were to vomit, if you were to whatever, none of it goes into your lungs. So you're totally protected. The anesthesiologist is doing all the work for you. When you are in any type of anesthesia lesser and you're semi-awake, but you don't remember, your airway is not protected. There's no tube in there. You're breathing on your own, or you use something called an LMA, which only covers your throat. And if you were to aspirate, if you were to vomit, it would go into your lungs. And that's kind of what we were talking about with Mounjaro and semaglutides. And there have been deaths because people vomited and it went in their lungs, and then their lungs shut down, and then they went to the hospital, and then they were on the ICU and they couldn't be ventilated and they dropped dead. I'm not by any means suggesting that conscious sedation, which is a massive part of anesthesia, shouldn't be done at all. If your anesthesiologist is badass, then knock yourself out. What we're referring to is there are instances where a patient is not a good candidate for conscious sedation. They are at risk. They should have general anesthesia. The patient is afraid. The surgeon doesn't want to lose the case. The surgeon tells the anesthesiologist, and the anesthesiologist buckles, and instead of standing up against the surgeon and saying, no, I don't think that's safe, we should do it this way, does it the way they want. And then there are some anesthesiologists that sort of, we called it MacGyver it, and sort of connect things. I mean, you're not, again, in Guatemala. When we're in Guatemala, and I've had both, I'm in Beverly Hills, endless amount of money available to the patient. In Guatemala, zero money. So I've seen all the spectrum. And when you have no choice and a kid's sick, you do whatever it takes. But you don't need to do it. It's elective surgery, guys. So this idea that they're Mickey Mousing or jerry-rigging or cutting corners for anesthesia is something that patients don't understand. And that's why when I tell patients during their consults, da-da-da-da-da-da, and my anesthesiologists happen to be two people that put my mom, my wife, my sister, my mother-in-law, my 4 nieces to sleep, were at my wedding. I tell every single patient that, because then they know that I'm not just going to pull some asshole out of my hat, show up that day, and God knows what they're going to do and not do. And then they're not going to have the balls to tell the surgeon, hey, what are you guys doing? I cannot tell you the times I've seen anesthesiologists fold to the surgeon. And they know what's going on is wrong, and they don't pipe up. Have you seen that?
All the time.
Right? You see it happen. You see that dynamic where the anesthesiologist is concerned because they're the other co-pilot, they're the other doctor in there, and they should chime up and be like, hey, Rady, yeah? The patient's not doing well. What do you, stop, and they do nothing.
Happens all the time. A lot of anesthesiologists just want to have like a good relationship with the surgeon, so they're invited back to the center again.
Right.
So they'll do whatever it is.
Right, because what happens if you as an anesthesiologist are like, hey, what are you doing? Why are you doing that? That's not right. What happens?
They'll have you leave, they'll call someone else.
The next time, I won't call you because you're annoying. You're a troublemaker. Oh my God, isn't that like what happens in every other place where there's a whistleblower? They fire them. So that's the reason why people don't do it. So as a result, really, again, like I said at the beginning, this whole thing, everything we're about to talk about, and we're going to talk about in a second episode, revolves around surgeons being responsible, orchestrating, and setting up the environment so it's safest for the patient. But we're going to end this episode, and we're going to have a part two of this episode of what we called OR Nightmares, operating room nightmares. And we're going to keep going because I think that this, for me, is one of my best episodes because it's really sharing the inside story, inside track of what's happening. And it shouldn't be done to scare you. It should be done to empower you. And I think that 90% of the times, if you're empowered, you can do well, but you should know the details. So, Paula, will you join us on a second episode?
Yeah, I will.
All right, guys, you're lucky. Paula wasn't even sure about the first episode. All right, guys, so that's going to be a wrap. As always, at the end of each podcast episode, I have 2 requests that I ask you. Number 1 request is if you like our show, please go and write right now. We're going to end this. I know you're driving or you're on a treadmill or wherever the hell you are. Just go and write a nice review. It makes such a difference. There's so many people that put this production together, put in energy. We're here on a Sunday, and then it allows them to feel good about this entire production. So we love that. And the second is share this podcast with everyone you love, because you don't have a clue who's about to go and have surgery next week, and then when you find out, it's too late. Hey, you should have listened to this episode. So share our episode, write a nice review, and we'll see you next week on Plastic Surgery Uncensored.